Wild Health is about optimizing you. We use genomics, blood work, biometrics, microbiome assessment, many other tests, and a conversation with you to come up with a full health optimization plan. What's the perfect diet, exercise, and supplement plan for you and only you? The Wild Health podcast is about optimizing all of us. Here we cover the cutting-edge science that gives you the base to be able to apply the personalized plan we give you as a patient. To sign up as a patient, go to wildhealth.com. Or if you're a physician or health coach and you want to learn how to do this for your patients, we're happy to help as well. wildhealth.com for all the information on becoming a patient or working with us.
Hey everybody, welcome back to the Wild Health Podcast. We have an interesting experiment for you today. This is, rather than just a Wild Health podcast, actually a collab podcast with the Brain Fitness podcast. The guys over there, Tommy Wood and Josh Turknett, have a great podcast where they talk about all sorts of neuroscience goodness. And today we're going to talk about cognitive decline. We're going to talk a little bit about overall brain health, keeping the brain healthy through middle age and helping reduce the risk of cognitive decline later in life, as well as what do you do when you start to see some evidence of cognitive decline or starting to manage mild cognitive impairment. With me today are the two hosts of the Brain Fitness Podcast, Tommy Wood and Josh Turknett. Tommy is a neuroscientist and assistant professor at the University of Washington in Seattle. He's got an undergraduate degree in biochemistry from the University of Cambridge and a medical degree from the University of Oxford and a PhD in physiology and neuroscience from the University of Oslo. Co-founder and treasurer for the British Society of Lifestyle Medicine and performance consultant to professional athletes in a wide range of sports, particularly Formula One. Josh is a neurologist, practicing clinical medicine, Alzheimer's researcher, best-selling author, award-winning musician, and founder of Brain Joe and the Brain Joe Academy, which comes up later in the podcast when we have a little disagreement about whether the banjo or the guitar is more important for brain health, which is just a little bit of ridiculousness for you. This is a cool conversation. It is very much a conversation rather than an organized podcast, but we do get some nice nuggets of knowledge in there. So I hope you enjoy.
All right, guys. Let's get started. We're going to cover two main questions today. I'm going to pose to Mike and Josh in turn, and then the rest of us will sort of chime in as well. But the first one is approaches to a patient or client who has maybe some concerns about long-term cognitive impairment, but certainly isn't experiencing anything right now. Maybe they're in their 30s or 40s. They come to you and they say, I want to make sure that I have the lowest likelihood of experiencing significant cognitive decline or dementia long-term. Mike, somebody comes to you, asks that question. What is your approach going to be?
Thanks, Tommy. I love that you gave me the easy question first, which is
Softball.
Great. It makes me feel good hanging out with a couple of neurologists, neuroscientists, PhDs. It's nice to take the softball first. I appreciate that. So, I mean, I see this all. This is our bread and butter at Wild Health. This is literally this and cardiovascular disease are the two primary things that people come to us for because they're concerned. You know, their family member has Alzheimer's or some sort of dementia. They've got cardiovascular disease in the history. They want to know what can they do to improve things, right? I mean, I think a lot of people initially or have had this concern that there's really nothing that you can do to prevent dementia. It's just kind of like, genetic or whatever it happens. We don't really understand it. We don't have any drugs for it. We can't do anything about it. And the good thing is that while some of that, there's some truth to that, there is a lot we can do about it around lifestyle change, behavior change. So my approach to a patient who comes to me with these dementia concerns or cognitive impairment concerns is really to start with the basics, obviously, right? So we practice precision medicine, so we're running lots of tests to understand the patient's baseline, and that includes not just a genetic baseline, but also an epigenetic baseline, as well as laboratory testing to figure out things like metabolic disease, vitamin insufficiencies, things like that. So holistic picture of the patient, starting with genetics. So With genetics, we look at APOE, which I think probably almost all of your listeners and my listeners have heard about. But we also use polygenic risk scores. There's been multiple studies published using thousands and thousands of different SNPs, looking at your risk for developing different types of dementia, late onset, early onset dementia. We look at all those things, APOE, Klotho, TOM40, as well as thousands of other SNPs, and try to assess what is this person's overall genetic risk for developing dementia. Now, that doesn't mean their overall risk, right? Like that's very different, because you can, of course, change your genes through epigenetics, right? But having a APOE4 is definitely going to increase your overall genetic risk, and that's going to have some effect on how aggressive we are with interventions, right? As well as having higher polygenic risk scores. We also look at epigenetic risk. So we've started using an epigenetic test that looks at about 9,000 different CPG sites, from methylation at CPG sites, to test for how you've effectively changed your epigenome, which, for anybody who doesn't know, is the way that your cells use your genetic code. So you can turn on or off genes within the cells through the epigenome. And we're starting to understand a little bit, not a lot, but a little bit, about how the brain epigenome changes. So we can look systematically at the different organ systems and understand how the epigenome is in the brain, and even age someone based on their epigenome, age their brain. For, I could say, Tommy, you're 40 years old, but your brain is 32, right? And that gives us some idea as to what the life living up to now has been like, right? So
those numbers sound great. I'll take it.
Yeah, you like that? You like that? Did Tommy party too much in college, and is his brain struggling from that? Yeah. Or did you play football and take a bunch of hits? Like, I can start to get an idea of what sort of impact your life up until now has had on your brain specifically, right? And then I look at other well appreciated clinical values, biomarkers for disease. A big one for brain health is going to be metabolic disease, right? Like, we know that metabolic disease is very closely related to cognitive impairment long term, right? As well as other things like your hormone levels, the vitamin D, your red cell distribution width, like all of these other markers that we think about as markers for inflammation, CRP, for example, and their effect that they could be having on the brain. Take all of that information, which is a ton of information, takes a while to collect, and you kind of massage it all together. And you start to understand, like, all right, where are the places that we could improve your likelihood of success or reduce your risk of having cognitive impairment long term? Are they metabolic, because your fasting insulin's elevated and your hemoglobin A1C is a little elevated? Are they cardiovascular, because your lipids are way out of whack and you've got some hypertension? We can really start to hone in on those things. Is it hormonal? Is it vitamin related deficiencies? All of those things can start to give us a sense. So in a way, I don't know if you guys have heard of Dale Bredesen or his approach to Alzheimer's. I don't follow a Bredesen protocol by any means, but I do like the holistic approach that Dale took when it comes to managing Alzheimer's and cognitive decline, not just Alzheimer's. Let's include all of the dimensions in this one, because I think they're all related. But I like the holistic approach, and when it comes down to it, it's the basics. It's a healthy diet, it's exercise, it's quality sleep. All of those things are 80% of the value, and how hard or how aggressively we pull on those levers is determined by your genetics, your epigenome, your clinical lab values. All of those things just determine which levers we pull on the most and how aggressively we pull on them. So I'll stop there. That's my approach. Please feel free to ask questions or tell me I'm terribly wrong.
I actually trained in Dale Bredesen's approach several years ago now. So yeah, I'm certainly familiar with it.
Yep.
I guess my main or my first question is related to how that applies. So if you think about the Bredesen approach, it's a fairly flat approach, right? You measure a whole bunch of things and then you try and plug all those holes at the same time as much as you can. And potentially listeners to your podcast and your kinds of patients are the kind of people who are willing to change 40 things at the same time. Whereas I know certainly some of the people who might listen to our podcast might be like, well, that just sounds really overwhelming. I'm not sure what I'm going to do there. So maybe, do you have any thoughts on a hierarchy or how how, you kind of said, right, you gave some examples of why you might go metabolic or versus lipids or some other things, but do you have some like a hierarchy in terms of how these things fit together, sort of like what you're gonna try and knock down first?
Yeah, yes and no. I mean, like I try not to have like these concrete hierarchies. And my challenge with Bredesen protocol, and I also trained in the Bredesen protocol as well and practiced it for a little while. My challenge was putting people on like, $1,000 worth of supplements a month. Like it was just too much. There was too many interventions, just like you said, Tommy. And like, what we've learned, we use health coaching at Wild Health. We, have a lot of provider visits. People are really, they get premium health care with us. Not everybody can afford that. Not everybody is willing to take on that level of intensity. But what we've learned even is that even with the level of commitment that we have from our clients, you can't give them 40 things to do to get better. Yeah. Like it just doesn't work, and I
even if they think they can.
Yeah. Even if they think they can, even if I think they can, even if they think they can, even if they should, all of those things, it doesn't matter. They're not going. I mean, you get a few things, every few months, right? Like you focus on a few things. So I do definitely have a hierarchy. In my mind, the hierarchy for dementia prevention and brain health is really focused on inflammation and metabolic health of the brain, right? Specifically of the brain. So reducing brain inflammation and improving metabolic health. Those things are somewhat intertwined in themselves, but those are the highest on my list, right? So if I'm looking at your laboratory values, your genetics, all those things, and I can tell there's inflammation, and I suspect that there's cognitive, there's CNS inflammation, then that's going to be very high on my list. If I can see there's metabolic dysregulation, that's going to be extremely high on my list, right? I'm going to put those above everything else, right? But I still take a very personalized approach to each person, right? Like, if there's other things, there's inflammation's pretty good and metabolic health is pretty good and lifestyle, your nutrition and fitness, you're meeting those goals pretty well, then yeah, maybe we focus on hormonal stuff or homocysteine, methylation. Maybe we, focused on micronutrients. Like, so I'd hate to say that I'm concrete with it because it really is personalized for each person, which I know is super annoying to hear on a podcast. I know it's something anybody wants to hear, but I can't lie.
Well, I think that encompasses the truth of it, that you have to figure out what's contributing in a given individual. Can you tell us a bit more about I'm interested in what epigenetic test are you using, particularly as it pertains to, say, cognitive risks?
We're using one a study came out of Harvard, or it's coming out right now, called OMIC Age, OMIC Age. It's through a company called True Diagnostic. But the nice thing about them is, I think that the age clock they use is the best, but they also have a systems age, so you can look at how each system is aging separately, which allows me to say cardiovascular health, brain health. Those are helpful numbers, I think, like, because they give you that sort of like sense of lifestyle. But the thing that I really like about it is they're using these, they're calling them EBPs, epigenetic biomarker proxies, which is entirely too long of a name. But it's basically like it's estimating your clinical lab values and like proteins and metabolites based on the epigenome, right? So it's like they took thousands of people and they looked at like, in people who have this epigenome, this methylation profile, they had this CRP, or they had this inflammation marker, right? And the nice thing about that is, like, when we're doing blood tests, I'm getting a very short period of time, right? And a lot of our values that we measure in the blood change, like, even throughout the day, right? Like, if I measured your CRP after Fran, Tommy, it would probably be 12 or something ridiculous, right? But like, if I measure it 16 hours later, it's probably 0.2, right? So where are those inflammatory markers land over time is where methylation becomes helpful, because I can get sort of a longer time frame. So rather than just seeing your CRP on September the 12th at 9 a.m. was 0.6, I can see what was your average CRP. It's almost like a hemoglobin A1C for in these other biomarkers, because you see the average over time, because it affects your epigenome over time. So that's kind of how I'm using that test to get like a longer term picture of patients' biomarkers.
And are you repeating it at some interval to track changes over time?
Yeah, we typically repeat. Right now in our clients, we're repeating every 3 months. So we'll repeat, and I don't repeat a an age test necessarily every 3 months, although I like to, because I want to know are our interventions having a positive effect? But I also want to remind them to keep working. And I found that that's been super helpful for behavior change, is that repetition. Otherwise, we naturally fall back into our normal patterns, right?
Really?
Without regular checking these things. And I think that's why a lot of, biohackers, for example, have, gotten excited about like, their own lab testing or running their own personal lab tests, because it's just this constant reminder of like how to keep on top of the interventions that they're performing, right? So I want to know, early feedback. Is this intervention actually working? And then I also want to like help keep that person on track over time. And we found that 3 months is really sort of like the sweet spot for that.
My final question for you before I throw this same question over to Josh is the role of the health coaches as part of this. Like, what are they doing? How frequently are they doing it? How are they interacting with patients to help support behavior change? Because like that human in the loop is still something that seems to be essential for all of this stuff.
100%. I mean, they are the most important part of the healthcare team, for sure. More important than the physician. I mean, I think it's good to have good direction, and the physician's there to create the direction and to help remind and things like that. But the person who is actually directing the interventions and directing the behavior change is 100% the health coach. So we've got patients that talk to their health coach multiple times a week. They're messaging with them. They're meeting with them on a weekly or bi-weekly basis, talking about, how their interventions are going, tracking their biometrics, their sleep, making sure that they're sleeping well, jumping in when it looks like they're overtrained or not getting as much training as they need. So, super, super important piece of the puzzle. And we found it to be really valuable. And, we published a study last October looking at sort of outcomes, and I think a huge piece of this is the health coaching part. But we found that within the span of a year, we had a reduction in people who came to us with elevated hemoglobin A1C levels. They actually resolved the prediabetes or diabetes in like 47% of the patients, which is about 15 times higher than you get with classical medical treatment. And I think that's because of health coaches, right? I mean, like, it's not like we're doing lifestyle change. It's like what we're doing is not insane, because in clinical medicine, people always talk about lifestyle change first. But the thing they don't have is they don't understand what type of lifestyle change is most important for that patient based on their genetics. So they don't have that precision piece, and they don't have health coaching. They don't have somebody to walk the patient down the road of lifestyle change. They just meet for 15 minutes in an office, tell you to eat better and exercise more, and then, send you on your way. And, big surprise, that doesn't work.
Yeah, they wonder why nothing happens.
Right.
Great. Super nice overview. So I'll ask Josh the same question. This is maybe less in your clinical practice, and you probably experience more people who have some impairment already. But imagine somebody in their 30s and 40s comes to you and says, "Hey Josh, what can I do to minimize the likelihood that I'll experience significant cognitive decline or dementia over the next few decades?" What's your approach going to be?
Yeah, so I think a lot of what, aligned in many ways with a lot of what Mike said. And, and especially the message that there is far more that we can do than I think most people have been led to believe. We really don't know what the upper limit of that is right now, because we haven't really tested it. And that any approach has to be holistic, because there is no single factor that leads to cognitive decline or Alzheimer's disease. It is many different factors interacting together in ways that we still don't fully understand. Different sets of factors for different people. So every case is kind of unique. So there's no one size fits all protocol. So it has to be individualized, and it has to be multifactorial and holistic. And I think that probably the main thing that I would add that the listeners of our podcast would be familiar with is the big picture is we want to try to build in as much resilience and robustness into the brain as we can at an early age. just as we would do in the physical realm, right? So, the stronger our musculoskeletal and cardiovascular system, the longer it takes for any decline to make a meaningful impact, the more resilient we are in the face of stressors. Same exact thing is true of the brain. And the way we build that resilience is with ongoing stimulation of growth and repair. And in the brain, we do that through lifelong learning and execution of complex skills, along with supporting our brain's ability to grow and repair and create substrates that mediate all those capabilities. And kind of that's what all this approach of supporting all those repair and recovery process is for. And I think we would argue as well that not only is stimulation key to building resilience and preventing cognitive decline, but that the understimulation of the brain kind of starts in midlife and progresses as we get older, typically, is the driving factor of age-related cognitive decline and Alzheimer's, and the most common form of it, because the health of the brain tissue is directly coupled to the cognitive demands that we place on it. And I think we just have vastly underestimated how much less stimulating the typical adult life is when compared to early life. And so the key then becomes, trying to continue to provide the brain the same level of cognitive challenge it received in our youth, through this continuous maintenance and acquisition of complex skills, which is a big undertaking. And certainly it's become increasingly accepted that continuing to lead a cognitively active lifestyle, should be a foundation of maintaining brain health, which is great. But I think perhaps the most important message that I want to get across is that should include much more than just thinking skills if we're going to make a real impact. So specifically, it also must include complex motor and perceptual skills. And we tend to equate cognitive activity with just thinking stuff or the sorts of things we did in school, math and reading and crossword puzzles. But cognition involves so much more than that, and that's only just a very small slice of it. And so if we limit our efforts to just thinking skills, then we're neglecting and not stimulating, large parts of our brain. So analogous to just doing biceps curls or something, So just as we know,
there's nothing wrong with that.
No.
There's just
no, just not being the only thing, right? And so, just as we want whole body workouts, right, for physical fitness, we want whole brain workouts for brain fitness, and especially if we have any hope of trying to recreate the cognitive challenges of our youth. And so it's important to understand what that actually looks like. And now I think probably the biggest oversight there is neglecting kind of skilled movements. So much of our cognitive resources are devoted towards planning and executing movement. And really, you could describe the brain's main job, the main job of cognition for sure, as selecting and executing our next movement in the world, right? That's our primary goal. We would need cognition at all if we couldn't move. So all of it really evolved in the surface of planning and executing movements. And so no surprise that so much of our cortex is devoted to that task. So if we don't include, those sorts of skills, then we're neglecting a big part of the brain. And to me, that's been kind of the biggest oversight in the initial efforts around brain fitness. It's stemming from kind of misconceptions about what human cognition really is all about. And so the ideal, if you have someone middle age and looking kind of what things to do to stimulate their brain, our ideal activities would be things like music, dance, the arts, skill sports. And that means not only continuing to do things where you may have developed some level of expertise, but also always engaging in something where you're a relative beginner, right? Where you're unskilled, because that's when your demands are going to be highest. That's where you're best replicating the kind of learning environment that you faced in childhood. So that's kind of the stimulation piece of it, trying to regularly, give this kind of whole brain stimulation, just like you would want whole body stimulation, and then doing all the things that we just talked about, that support all the repair and recovery, right? That is what drives the brain to grow and repair. If you don't have that signal to begin with, all those other factors are going to be a lot less meaningful because there's nothing there to repair and grow in the same way. The analogy there being if you can't just eat protein to build muscles, you have to have the demand signal to begin with. And then you want to fully support the body's ability to repair and recover from that and grow. So those are the two big pieces: the stimulation and support side.
Josh, I'm curious, like sort of along the same line. I mean, I love like giving people a prescription to like learn to play guitar and like take up surfing for the first time at 45. Like,
Right.
like it's one of my favorite things to do because
Yep.
like they're like the doctor told me to learn how to play the guitar. It's kind of fun.
Yeah.
But so I love that stuff. I think it's great. Like let's challenge people in new and unique ways, which not only I think also gives them like some personal fulfillment, which in some ways it's kind of hard to like separate like the happiness and personal fulfillment and purpose and meaning and all those things from cognitive performance and cognitive health. Like those are hard to separate. But I'm curious, like a lot of the things that you said around like challenging the brain sort of reminded me of this this study that I saw presented recently. And I'm just curious on your thoughts on this. And this is I'm taking things in a different direction here, fellas. Sorry about this. But, did you see the study that came out in Nature from Stanford on the use of ibogaine in vets with post-traumatic head injury and PTSD? It basically found that they took vets, tested them before they went through this ibogaine protocol and then after the ibogaine protocol, and they had like a 90% improvement in their PTSD scores and like I forget the actual improvement on their overall disability scores, but it was massive as well. And I've seen like multiple studies showing that psychedelics increase BDNF levels and create this like plasticity in the brain. Is this also having like a similar effect as like, say, for example, learning to play guitar or learning to surf when you're in your 40s and your 50s? We're just basically challenging the brain and forcing it to get plastic and like and change things up a little bit. Is that what's going on?
Do you want to take a stab at it, Tommy, or you want me to take first
Oh,
pass?
no, you were going to go.
All right. I didn't know if you were familiar with the actual study. I'm not familiar with the study.
I am familiar with the study, but yeah.
I figured. But I will say that so that's super interesting, and I do think that one of the challenges, like one of the reasons why as adults we tend to learn less, is because we've developed so many automated routines that we can rely on to get by each day. So there's no need for it. And it also can be an impediment to learning something new, right? If you always have an old habit or an old pathway you can go down. So, and there does seem to be evidence that psychedelics, at least in their role for mental health, are beneficial in sort of opening up, a plasticity window for maybe habits of thought, right? Being able to change, making it a lot easier for maybe a period of time to form new pathways. Whereas in the past, without it, you would just keep going down that same one, right? And there may well be, it's entirely possible that could apply to other domains of cognitive function. Not just thoughts, not just mental health, but other areas. Always you can certainly there's downside potentially to having the brain be too plastic at any given point, but but there's certainly the potential there that it's certainly conceivable that could be used to facilitate plasticity. And I do think that if you kind of used any metric to look at how cognitively demanding a person's life is, how much plasticity they're stimulating over the course of a given day or week or whatever is pretty good, is about as good a metric as you could have, right? So from that standpoint, anything that would kind of open that up should be beneficial.
Awesome.
I think that my main point was actually going to be very similar to Josh's, which is that in many situations in those with mental health issues, it's these habits of thought that you have, these well-worn tracts of thought pathways that occur, and it's being able to get out of those by using psychedelics is one way to get out of those, right? If you're essentially shutting down the default mode network, you are you're preventing those continuing thought processes from happening, which then allows other processes and connections to be made, which is then ideally you need some combination of both, which is why therapy is such an important part of psychedelic treatments, right? Because first you need to maybe create the ability to create new mental thought pathways, but then you need somebody to help you develop those, right? You need a trainer in that aspect of the gym in order to help develop that. It's not enough to just take the drug and hope that everything's going to fix itself. So that's why, setting and a well-trained therapist is so important, because it's like you create the opportunity for plasticity, but then you actually have to drive plastic growth into the connections and areas that you want to try and support.
I think there's, I think Johns Hopkins was doing a study, psychedelics in MCI, but I haven't seen any results yet on it. I know they were performing it, but I think that would be interesting, because it really does speak to like a similar sort of approach, right? In terms of like challenging the brain and the plasticity that we're discussing, or that you brought up, Josh, with just sort of helping prevent dementia through challenging the brain.
Yeah, anytime you're doing that, right, you're going to be stimulating growth processes, right, through plasticity, and we know there's lots of evidence that is directly beneficial. So it's certainly biologically plausible, for sure.
I'll be interested to see those results, because generally, in the setting of psychedelics, you create a more distributed connection across the brain. You have greater brain entropy, right? More parts are connected to other parts. Whereas in the younger brain that has higher relative cognitive function, you have these tighter knit networks with specific functions. So and when you're training the brain by developing new skills, you're strengthening those task specific networks. So it'd be interesting to see whether increasing brain entropy through psychedelic use in when cognitive decline has already started is beneficial, versus training to reconnect smaller task specific networks. Maybe both are helpful. I don't know the answer there.
Right. It's probably the how it's done is probably the critical factor there.
Probably.
So I think like across both of you, a fantastic wealth of information. That the main thing that I was going to potentially add, and it's nothing new, it's just part of how I think about this, and it's part of the problem that we've had when studying both risk factors and interventions for cognitive decline in particular. But this is pretty much the case for any time we do anything in neuroscience and neurology, and in general, we fail spectacularly at developing therapies, which is that we assume that everything is linear and just stacks on top of each other. But one intervention on its own may not be enough if other things aren't in place. And so the best example that I have, people listeners to our podcast would have heard me say this before, is the interaction between omega-3 status and homocysteine, which has now been shown in multiple randomized controlled trials that you can fix one or the other and have no effect. But if you fix both, then you see a synergistic benefit in terms of brain atrophy rate and cognitive decline rate. So the literature is littered with studies where people give omega-3s and then say, hey, we didn't improve cognitive function, therefore omega-3s don't work. But actually, across 3 randomized controlled trials now, at least you see that if you have low omega-3 status, but you don't have high homocysteine, your homocysteine is 11 is probably the best cutoff, although ideally it might be a bit lower. Then you see benefit. So these factors interact, and because we know that if you want to get DHA into a membrane in your neurons, then you need methylation to be working properly, because that's what connects your fatty acids to your triglyceride head chains, or phospholipid head chains. So the problem that we've had in general in this sphere is that we assume that we can just do one thing and see benefit, but actually context and these interactions are really important. And there'll probably be a whole bunch more failed trials if we don't start to take that into account, as well as maybe taking stimulation into account. And this is like Josh and I wrote this paper a couple of years ago where we made this case about demand being this critically important part of cognitive function. And so you might imagine, right, if it's anti-amyloid or treatments or some other treatment, like maybe there's some role for those, absolutely. But it's like if you're not creating cognitive demands to actually rebuild these connections and neuronal networks, it's like taking a protein shake and expecting to build muscle without ever going to the gym, right? You actually need this stimulus to be occurring. And it might be that, again, more failed trials are coming because we're not creating the stimulus that then can help repair, or which these therapies may support. So I think that's just an important thing to take into account as we foray further into this, particularly in sort of the research and clinical setting.
That's great, Tommy. Can I ask another question of you guys, since I have you both here? I'm just curious. Where are y'all with ketones and I guess maybe we just start with like prevention, ketogenic diets, exogenous ketones. Where do ketones fall in your world of benefit versus nada?
Do you want to go first, Josh?
You should go first.
All right, I go first.
Sure.
So I think there's definitely a lot of promise here in my research. Acute brain injuries, I think ketones have a lot of promise in both neonatal brain injury and traumatic brain injury concussions, which both of which I study in the lab. I'm not sure we can say we should definitely do it, but certainly if I had some kind of significant head trauma, it's going to be low enough risk with potential for benefit that I would certainly institute some kind of ketosis for at least weeks after the injury. And one of the main reasons for that is, at least in the developing brain, ketones are the primary biosynthetic precursor for actually building the brain in the first place. The developing brain takes ketones and turns them into cholesterol and fatty acids that create membrane structure in the brain. And if you've injured the brain, you need to rebuild structure so that, in addition to the potential anti-inflammatory and other benefits, I think that's a primary one. In other settings, there's certainly some interesting aspects of ketones on cognitive function. There have been a couple of studies. One, I think in individuals with obesity, came out recently from Jonathan Little's lab, which showed improved cerebral blood flow, and with that, improved cognitive function with a ketone ester. And with the sort of demand hat on, if you increase cognitive demand, you're going to increase cerebral blood flow through neurovascular coupling, and then that's going to be associated with improved cognitive function. And related to that, there was another study that showed if you give a ketone ester to individuals, you increase network stability in the brain. Like I talked about, as we get older, our network stability decreases. Network stability increases with a ketone ester. So it could be that in some settings, particularly when cognitive function is already eroded to some degree, then we know that the substrate changes which parts of the brain are working. It's the same. They've done studies with fructose and glucose. So if you give somebody pure fructose, they decrease activity in the middle temporal gyrus and the prefrontal cortex. So the areas that are preferentially affected in many dementias. Whereas if you give glucose, that doesn't happen. So we know that the substrate you're giving to the brain changes which areas of the brain are most active. And you can imagine a scenario where ketone bodies change network stability. They increase activity of certain areas of the brain that have maybe been less active for whatever reason. That then is associated with improved cognitive function. And you see that with that increased cerebral blood flow, like they saw in that study. However, other studies by that same group in type 2 diabetes didn't see an effect. So I think there's still a lot that can be sorted out there, but I'm certainly very interested in ketones as an intervention, at least after injury or in the setting of some cognitive impairment. Whether everybody needs to be on a ketogenic diet for prevention, I think probably not, because there's not really enough evidence there to suggest that, and there are certainly people who are cognitively very capable into their 10th, 11th decades, and they probably never saw ketone in their life. So it's certainly not essential, but once brain function has been impaired in some way, I'm very interested in ketones as a potential intervention. That's my spiel.
I would agree with all that. And then I would just add that I think my default strategy, in the absence of the evidence that would clearly indicate one way is better or not. My strategy is to minimize environmental mismatch as much as possible. So, if we look at our evolutionary history, probably, plenty of times where we were in ketosis. So having maybe a seasonal approach to it and, being fine with if you're eating, a lower carb diet in the wintertime, and, having some natural ketosis to mimic that pattern, I think that's a very reasonable thing to do. And I think we both would say if someone wanted to do, cycle in and out of ketosis as a potential cognitive protection strategy, that's a very reasonable thing to do. It's not harmful for sure. We just don't have enough evidence to say it's definitely going to be helpful. And it's also super important to say compared to what alternative. So in many cases, the alternative may be much worse. So in that case, for sure, a ketogenic diet would be helpful.
Yeah, we're all on this. We're all on the same page here. Mostly like little harm, in my opinion. Mostly thinking about it with MCI or early cognitive impairment. So okay, cool. Cool. Thanks for that.
One thing I will say, I was looking into this recently for the setting of cognitive enhancement in somebody who's relatively healthy for some experiments, and I sort of canvassed the opinion of people who are experts in this arena. Brianna Stubbs, Dom D'Agostino, done a lot of this active research, and their one main caution was you might start to see negative effects if you elevate BHB or beta-hydroxybutyrate too high. So, targeting maybe 0.5 to 1, maximum 2 millimolar, maybe in certain scenarios, particularly as, somebody becomes sleep deprived or stressed, right? If there are these challenges to cognitive function in place, you may see some benefit. But if you elevate it too high, then you might start to see impairment. So
interesting.
If this is a strategy that people are interested in, just like you can have too much of a good thing.
Why did they give you a sense as to why there's impairment? Like what mechanism they're seeing there, and also maybe what sort of impairment, like reduced performance or anxiety, or what are they seeing?
Yeah, so all of this at this point is anecdotal, but across the few studies that do exist, it seems that I haven't seen anything about anxiety or symptoms like that, but just so if you expect some kind of, say, improvement in working memory or executive function in a standardized cognitive function test, you may see some improvement at lower levels, but if you went above that improvement would go away. So it's not necessarily that you're causing active harm. It's just that any benefit may have been counteracted. Although, and again, this is sort of like just people testing this out in the field. Not good studies to say refer to and personal experience. Sure. That's just kind of where they're landing at the moment, I believe. I don't want to speak for them, but that was kind of what I took away.
That's interesting. We're using exogenous ketones quite a bit in some of our professional athletes for like cognitive enhancement, pre-performance. And we've noticed that the esters that give you the higher peak tend to have a greater subjective effect on cognitive performance than, say, for example, the slower acting ones. So seeing a higher peak, having greater cognitive performance improvement, but that's all subjective. We're not objectively measuring that. So it's interesting to hear that because it's a little bit in disagreement with what we're subjectively seeing, at least in our clients.
So what I'll say is there are a lot of examples. Caffeine, most of the stimulants, methylphenidate, and the related amphetamines, and I would be surprised if ketones didn't fall into this category as well, is that you see improvements in mood and subjective cognitive performance, but actually cognitive performance objectively measured gets worse.
Okay.
And so for complex cognitive functions, with all of the stimulants, at least caffeine and some of the amphetamine-based stimulants, you see an improvement in subjective performance. They feel better, they think they're performing better, but actually objectively they're performing worse. So before you take somebody's word for it, I would actually find a way to objectively measure their cognitive function.
It is almost certainly
going down a rabbit hole.
Depend on the skills being tested, right? There may be some functions that are enhanced and some that are not. So again,
not to go any further down the rabbit hole, but it does bring up an interesting question of like, is the subjective experience of improved cognitive performance more important than actual
Yeah,
objective
right.
improvement of
Right.
cognitive performance when it comes
What's
to
your goal? Yeah.
yeah, when it comes to like a performance metric, right? Like a non-cognitive performance metric, like how fast can you run and catch this football? Like that's not necessarily cognitive performance. And a lot of it has to do with the psychology associated with I feel good, I'm gonna go run fast and catch this football, right? So, interesting stuff. All right, sorry, another rabbit hole.
In endurance performance in particular, the psychology has such a massive aspect. So if you're making somebody feel better, they will work harder. If you're talking about complex motor skills, that's where things get tricky, because they may feel better, but they may not be performing better. But if you're talking like triathletes, runners, those cyclists, I'd take the subjective more seriously than if you're talking rugby players or tennis players or table tennis players or neurosurgeons. Yeah. All right. So after that rabbit hole, and maybe potentially important as well for the subjective, we'll now go to somebody who's experiencing some cognitive decline, or at least they feel like they're experiencing some cognitive decline. Josh, we'll start with you, because this is obviously something that you came across in your practice. Somebody either subjective or probably some objective as well, cognitive impairment. What's your approach in terms of minimizing the likelihood of, or maybe we can reverse some of it, or at least minimizing the likelihood that this person will transition into full dementia?
Yeah. So that's a scenario I encountered many, many times. So I'll kind of focus on maybe an older patient who's noticing some cognitive impairment, maybe has some signs of that on their examination, but it's still mild or early. And walk through my process there. The first step is always going to be identifying and addressing any easily reversible or reversible issues, I should say. What we're trying to do in this scenario is correctly diagnose the source of the problem, and being extra sure that we look for reversible causes. Then the central question in a case like this is going to be: is this symptomatic of a neurodegenerative illness, or is it caused by something that's reversible? And the reason that distinction matters is because you can potentially restore cognition back to normal in a reversible cause, which isn't typically going to be true in a neurodegenerative process like Alzheimer's, given that there are still no meaningfully effective drug treatments. So you want to you want to be as certain of that diagnosis as you can be before making it, and part of that involves identifying and addressing any reversible issues. And it's actually very common for people to experience cognitive decline from relatively easily reversible factors, especially as they're getting older. One reason for that is that we're just generally more likely to chalk up any deterioration in cognition to old age, just because of this sense of inevitability that people have around cognitive decline and aging, which is one reason we think it's so important to stamp that myth out. And another important thing here is that people lose cognitive resilience with age and become increasingly frail. So when this happens, a stressor that wouldn't have led to any perceptible decline, earlier in life, can be enough to cause significant impairment once they've reached a point of cognitive frailty. So what are the main reversible issues to look for? And what I mean by that is that the disruption in cognition is entirely functional in nature, right? The structure or the hardware can still support normal cognition, but something is interfering with its operation. And I'd say the big three ones in my experience, one would be sleep issues or sleep disorders. Anything that's leading to chronic sleep deprivation. Sleep is when memories are consolidated, so memory loss is a common symptom, and more likely again if someone is already cognitively frail. So a detailed sleep history, quality and quantity, looking for signs of any potential sleep disorder, the two most common being restless limb syndrome and sleep apnea. And so there it's, does your partner ever hear you stop breathing, or do you ever wake up, choking or gasping for breath? And again, that can be, sleep apnea, especially the older someone gets, can cause profound memory issues that can be reversed with treatment. So just in general, a detailed sleep history and investigation for any disorders is super important. The second one, mood disorders, depression. So the formal diagnosis for this is pseudodementia because it can present like a dementia and cause significant cognitive disturbances, again, much more likely in the context of cognitive frailty. So again, history there, looking for things like depressed mood, crying episodes, restricted affect, and maybe the most useful sign being that someone has become less motivated to do the things that they used to enjoy. The challenge with this also commonly coexists in the context of neurodegenerative illnesses, so it can be tricky to determine whether, this is the sole contributor or part of something bigger. And many times you can't make that distinction, at the outset, and have to see how things evolve over time. But this is, again, in the reversible category because the cognitive deficits are functional in nature. The brain can still support normal cognitive function. Treating this in practice, though, can be challenging just because of the challenge of treating depression, the limitations of pharmaceuticals, and the challenges of implementing the lifestyle changes and other therapies that would be truly beneficial. But important to identify, so to make sure you're addressing the right things and prioritizing time and energy. And then maybe the most important category would be medications. Simply because super common, easiest to fix, oftentimes the most dramatic. So I'm sure many listeners know that it's real common for, as people get older, to be put on a huge number of medications, many of which impact the brain. The big offenders here would be the antihistamines. So people who take Benadryl to help them sleep, don't do that. People who are the other one is meclizine for people who take that chronically for vertigo. And both of those impact learning and memory due to anticholinergic properties, so not even related to their direct clinical benefit. But they block the action of acetylcholine, which we know is critical for learning and memory. So can cause very significant cognitive impairment, especially as someone gets older. And then there's directly anticholinergic medications. These are most common, the ones given for overactive bladder. So the acetylcholine is the neurotransmitter used when that stimulates the bladder to empty. So blocking it helps with that. Unfortunately, it also has the cognitive side effects, and oxybutynin, which I think is ditropan, and tolterodine, which is Detrol, and there are a few others. But those, again, can cause, there's some cases of a very profound, cognitive impairment. People diagnosed with later stage Alzheimer's disease and then fully reversed just by taking off medication. Medications for depression, and the worst offenders there being the antipsychotics, which can cause what are known as extrapyramidal symptoms by blocking dopamine transmission. And that leads to clinical symptoms that are virtually identical to Parkinson's. So slowing of movement, possibly a tremor, and then slowing of cognition. And again, that could be very significant. Started to see a number of these once when Abilify started being used to treat depression, which is an antipsychotic. So should be a very high bar in using that category of medications in an older person, and only choosing the ones that have the very lowest likelihood of causing these issues with extrapyramidal side effects. And there are really only a couple that meet that criteria. Some of the older antidepressants used to do this a lot. They're not used as much. Generally, the SSRIs are going to be the safest, the only ones that I really feel comfortable using in this scenario. And even there, the lowest dose for the shortest amount of time. And then I guess the last would be the benzodiazepines and opioids, so the benzodiazepines, things like Valium, Ativan, which people are taking for things like anxiety or sleep, opioids for chronic pain, probably less commonly than it used to be. Neither of those should be taken chronically because they lead to all sorts of badness beyond just their cognitive effects, but it still happens. But they're terrible for cognition, especially the older someone gets. And I should mention too, if we're on the topic of drugs, that also important to check for to recognize that alcohol can also do it. And again, the cognitive effects with that are going to worsen with age. So can't ever assume that you'd be surprised that who's drinking sometimes. And as it is with any CNS acting drug, the more cognitively frail you are, the less dose it takes to cause significant issues. So it may not take much to cause impairment as someone gets older. So those are the kind of the big ones. The other is just polypharmacy in general, just the number of medications and interactions. So minimizing as much as possible, and especially the ones that impact the CNS in any way. And then the other thing, so if you've kind of gone through the process of ruling out reversible causes, suspect a neurodegenerative illness, then the next step would be make high impact lifestyle interventions. And if we think of this back in terms of the stimulate and support model for brain health and fitness, we're going to focus on the kind of the highest impacts of items. And on the stimulation side, I think the biggest impact that can be made by far is trying to ensure adequate social connection. So if we think about our three core cognitive capabilities, the big three we built in childhood: walking, talking, and socializing. At this stage, we really want to prioritize regularly challenging and supporting the networks that mediate those functions. And the best way to do that is, I think, to have plenty of opportunities for connection and engagement. And, as we've discussed, it's quite common for people to become less or more isolated and less connected as they age, which is likely a significant driver of cognitive decline and dementia. Another reason why this should be a big priority. So, connecting people, for me, connecting people with community resources that could help serve that need was what I would try to do. So connecting with a senior center or the local Y. And I will say that the people who did this, where this actually happened, who had regular stimulating engagement, did so much better. I remember one woman in particular came with early AD or early Alzheimer's, got really involved with theater in her senior center, was in all the productions, and did amazingly well, like multiple standard deviations from the norm, and remained, independent for a very long time, despite clearly having early AD when she presented, and we would all marvel at how well she was doing. And I don't think it was a coincidence that she was so heavily engaged with theater at that time. And this was long before started viewing things through the lens of the demand model. So I think overall, this was always the best predictor of someone's pace of progression, was how connected and engaged they were. And the ones who were the most progress the slowest, and the loneliest and most isolated did the worst. So I think just individually and collectively, this is where I think so much of our energy should be focused. So yeah, those are probably the big levers that I'll focus on. I'll leave it to you guys. Anything else?
I'll just quickly say, I know we have to wrap up in a minute, but there is some evidence, maybe less so for engaging in theater, but for this kind of approach, even in individuals who are, approaching a very high risk of cognitive decline, or sort of going into cognitive impairment, like the Finger trial, which came out a few years ago, which took people at high risk of cognitive impairment. And they made diet changes, physical activity changes, so aerobic exercise or resistance training. They had a cognitive stimulation, and then they monitored cardiovascular risk, and then compared to a control group, they saw significant improvements in multiple cognitive functions, including executive function and working memory, I believe. So, even in that setting, there is, once you get to frank dementia, it's probably too late. But even once some changes have happened, there's still scope to use these lifestyle and demand interventions to improve function. So that was the only piece I was going to say. Mike, any thoughts on any of this, or to sort of wrap up our conversation as we get towards the end?
Yeah, I think Josh hit the nail on the head with how do you start off thinking about dementia? In my mind, it's all about making sure you hit all the don't misses, right? So don't miss the thing that's not actually dementia, like normal pressure hydrocephalus or neurosyphilis or HIV or something that is truly treatable and reversible. You mentioned a lot of those, Josh, and then probably the more likely ones as opposed to the less common ones that I just mentioned. But I'd throw a couple more in there, like thyroid function, vitamin deficiencies, B12, vitamin D, things like that. So sort of cross apply all of the things that I said to your first question, Tommy. Like look at the overall holistic picture, right? All that stuff's still important, right? Metabolic health. All of those things should still be applied. Like I've seen people who, stop taking their HRT that they've been on for a long time, and then all of a sudden they started having, maybe that wasn't necessarily the cause of the cognitive decline, but it was, the thing that finally tripped them over the edge, so that you actually caught it, and then those things improve when that stuff gets intervened on. So it's a lot of and then beyond that, in social connection, overall general health, I will say it gets way more challenging to manage health issues in this group of patients, depending on the degree of cognitive decline that we're talking about. It's the more important thing than even having a good physician or healthcare team to direct is having someone in their life that can help direct them, make sure that they're taking their medications, taking their supplements, eating the way that they should be, because it becomes much more challenging to manage this patient than the person who is in, there for prevention. So, that's all I'll say there. I think we hit that one pretty well. I think this has been a really awesome conversation with just the right amount of rabbit holes and tangential conversations. The perfect amount of rabbit holes.
It's not easy to do.
But I think a great intro to sort of approach to cognitive decline. How do you start to manage it in midlife before it even happens? Just prevention, and then starting to think about how to manage MCI or early cognitive decline. So I think it's been great. Any other thoughts from you guys?
Yeah, I think that we'll emphasize earlier is better, but it's also never too late. There's as we've said, there are interventions that matter at any point, and it's so much more than just what pill are you going to be prescribed.
100%.
Yeah, no additional thoughts from me. I think we've covered everything. This was a fun experiment. I think it turned out pretty well. Very cognitively stimulating for me, so I'll take that away. Although I'll have to go learn some banjo later to stimulate my entire brain. But
I don't know if banjo works. Guitar.
That's right. That hurts. That hurts.
You just we've got to do a whole other hour of a podcast now while Josh tells you about why the banjo is the most important cognitive stimulus that's possible.
Yeah, I can't wait.
That's right.
Wait.
Part 2.
Thanks, fellas.
That's coming up.
All right, thanks, guys.
Thanks so much for listening to the Wild Health Podcast. If you want more daily health education, be sure to follow us on Instagram, which is filled with health optimization how-tos, grocery shopping lists, guided breathwork posts, myth debunking, and so much more. You can find us at Wild Health MD on Instagram.